Thank you very much. I've kept busy yesterday, one session, morning session, today, 3 session. But this is a very important topic. So much of controversy has erupted in molecular classification of endometrial CA. All the basic FIGO staging, what we believed, has been totally thrown out of the window. Can you ever imagine you may have a stage 2 high risk endometrial cancer just because they are pole mutated, they don't need any adjuvant? It is unthinkable. Imagine that you have stage 1B, you have a tumor which is more than 50% mammary invasion, you have a FIGO grade 3 high grade. Traditionally, you would have given Wald brachy if adequately staged node negative, or EBRT with Wald brachy if nodes are not analyzed, and they would also be discussed in MDT for probable 4-paclitaxel. And now you just have to do NGS Sanger technique in a Illumina for pole, and if it is mutated, not required. Unthinkable it is what has happened, and people can't digest that. Is this really the advance that's happening? So far, all the decisions advances affected medical onco, so you're very happy. Let them scratch their brain, read and come. Surgeon, good surgery was there. Now suddenly for us also things have changed. Even if you imagine if you have a p53 mutation, all the patient would need chemo radiation. Then people say, do you scratch and go to paraiotic and dig everything? Either way they know it. So first time all these advances come to the surgeon's doorstep, so you're afraid, because you need to know also update like medical oncologist. I always say fun. If medical oncologist goes for a vacation for a week, comes back, so much things have changed that 1 week they have to study to restart the practice. So this is very complicated topic. It took like weeks together for me, in spite of having attended IGCS. I was there. Then I also attended ASGO. I read a lot of these chapters, being part of panel even in IGCS New York. Very tough to analyze. I will try not to confuse you, but put in nutshell how to do it. So hopefully you will not get confused like I was, but know how to change. I bring warm regards from Aster International Institute of Oncology. It's a 4 big cancer hospital in Bangalore and over several across the world, where all multi-super specialty function is happening. Traditionally, in endometrial cancer, all we asked, when I was in Mayo Clinic, when I was doing the Gynae Onco Fellowship, we just asked size less than 2, more than 2, more than 50%, less than 50%, grade 3, story khatam. That's it. Low risk, high risk, low risk, simple hysterectomy, nothing more. High risk, do a high paraiotic lymph node dissection, laparoscopic, open, robotic, doesn't matter. And then think node negative, goes for Walt and chemo, and then, node positive, EBRT and chemo. Very simple it was for us. That's it. That story was over. Then little bit, those time noises about lymphovascular space invasion was done, but it's academic, lymphovascular space and perineural, all that is just to be documented. We never changed. But things have now totally changed the way it has happened. In addition to all this, molecular classification has rapidly come, especially when Astro and Estro has also adopted them completely. So what is the current basis? If you see ESMO, ESGO, NCCN, we have low, intermediate, high intermediate, and high risk. So confusion. This is all because of POTEC trial. All radiation oncologists to blame. I hope any radiation oncologist is here. So, we love low and high. Like you do Oncotap in best, low, high, over. Intermediate, big nuisance. That's why Memoprint is better or EndoPredict is better. You make a patient spend a lot of money to know low or high, and again you say, no, it's intermediate, so my decision is fine. Then why to spend the 2.9? Like you could have gone for a vacation, come back and made patient, save that money. This part came because of POTEC 1, 2, 3 trial, where instead of low and high, it came as low, intermediate, high, risk. So much of mess available for us. Okay. So this was the current risk stratification before an era of molecular. All less than 2 centimeter, grade 1, grade 2, 1A non-muscle invasive, or less than 50%, no lymphovascular low, nothing required. Surgery will cure them. If any one of them is little violative, preferably more than 50% with low factors, intermediate. High intermediate was LVSI is now positive, because that was one of the very important predictor in addition to higher grade. That is high intermediate. High would be node positive or stage 2 beyond. So quite simple, you know that first you don't have to do. Second, probably we can get away with Wald brachy. Third, you decide EBRT, some chemo. High, everybody needs chemo radiation. So very, very simple for us. These are all that changed. But now totally, immunohistochemistry finding. Remember, there are 4 important markers we do. P53, then, MSI, MMR, depending on you do by IHC or you want to do it by, Sanger's NGS, and then POLE. Based on this, one test cannot be done on IHC. You can do MSI and you can do P53, ER, PR, HER2/neu all on IHC, which is very easy. Most of the hospital have. It's few thousand rupees. Report is available in 3 days. But POLE has to be done not on IHC but on a Sanger sequence, which is NGS, which is expensive. Only there are 2 labs in India who are currently doing, which I routinely use. So now the tumor profiling has totally changed. This is the old way we studied endometrial. Type 1, type 2. Type 1, very good, obese, postmenopausal, hypertensive, diabetic, ER positive, HER2 negative, less chance of node being positive, FIGO grade 1, less than 50%, good profile. Type 2, postmenopausal, thin ladies, hormone negative, HER2/neu positive, node positivity very high, higher grade, needs chemo radiation, poor outcome. But all this has been now thrown off, because this was the risk stratification we all studied based on Annals of Oncology published in 2016 to guide. But the problem in this was, what we presumed as low risk also started recurring. What we thought at high risk, we overtreated. And there is a group of patients who don't recur in pelvis at the vault, but they fail dramatically in the peritoneum or lung, liver. So we were not able to distinguish, certain low risk in peritoneal cavity, high risk are not failing, intermediate, high intermediate are failing systemically. So we are not balancing the adjuvant chemo versus radiation. What happened is, with the trend, there was a over treatment of low risk and under treatment of high risk. The most danger in onco that can happen is over treatment of low risk, applies to all, breast, endometrium, gynae onco, everything, and under treatment of high risk. So what happened is, people in UK used to just do hysterectomy, not touch the nodes. So you would presume that it is stage 1, and they used to give EBRT. So we over treated the low risk. If they really actually required chemo, we undertreated them. 76% of women in early risk received radiation. Imagine, it's not something easy. Spend 1 to 2 lakh rupees, 5 weeks, delayed complication, proctitis, broader problem, not justified. On the contrary, because you're not doing proper staging, you miss that node positive stage 3C, or you're not doing molecular profiling who would be P53 mutated, and chemo is more important than radiation, and they all recurred. You had one good chance to cure the tumor. In oncology, you must be damn scared when you see early cancer. When it is advanced, you say cancer is bad, jaise bhi ho, recur hone wala hai. You mess up, God is with you. But when you have early, there is no reason that lady is not cured. You must be very scared. When I see early cancer, I get scared. I sit, I discuss, because one good chance is there, and we should not mess up and blame the cancer. So early cancers, don't undertreat. Same way, don't overtreat a patient which is truly early who doesn't need. So we understood that histology alone didn't decide. There is some prognostic separation that is required, which we are missing. Essentially, the whole classification changed based on this TCGA genomic atlas for endometrial CA. Those who have read, remember the signature. This is which showed POLE, MSI, copy numbers, P53. This is a landmark paper which changed everything. Remember, when you change the staging, prospectively you have to apply and find that this new changing made an impact. Retrospectively, you have to analyze and dig all thousands of cases in serial data based on this to show that the treatment changed. That's how a new FIGO on cervical cancer came. They introduced subclassification in cervical cancer. They found that when you use the 2 centimeter, 3 centimeter criteria size and the depth, then the treatment changed based on that. So this is how the molecular thing looked, that progression-free survival versus months. You can see that if this patient had a POLE mutation, practically all are cured. It doesn't matter their stage 2. Stage 2 means what? Cervix deep involvement present, more than 50% present, even though they are FIGO grade 3. Imagine there is one test which can separate that intermediate, high intermediate for a superb. Look, practically 100% of them have progression free. Now, if you come back to green, so if they are unstable MSI or deficient, not proficient, deficient, they suddenly drastically start having more progression. Means they lost about 20-30% of the women are dead by 5 years, followed by the type of P53 you have. So if you look back, the worst would be if you have a P53 mutation, 60%, 60 out of 100 women are dead, even though they may be 1B. So these are the 2 landmark things which told us, this is the TCGA genome atlas, followed by the analysis from the CR data, which changed everything. So we knew this. Type 1, type 2, very easy. how to integrate now into, okay, Pole mutation, class 1, very good. Then we have MMRRD, how to do it. Remember, MMRD, MSI is done in IHC, very easy, few thousand, you get report in 3 days. But only Pole is something which you have to do it on, Sanger sequence. So it's not easy, costly, expensive. 2 lab do it. They charge a lot of money. So even though the current guideline US is to do that and then come down, we go lower down in India. P53 is done easily. Then, MSI, MMR is done easily. ERPR, HER2 done. So the last one, the worst of all, is P53 mutation. That would change everything. Practically, most of them would need chemotherapy and radiation. So how did we integrate this, and how the changes now happened with this particular area? Roughly screenshot I'll give you. Worst is P53. Luckily, they constitute 5 to 15% of all endometrial CA. Usually, they are high grade. Tumor infiltrating lymphocytes are there. And then they need NGS Sanger hotspot to identify. And they are the patient who are type 2, what we studied, low BMI patients. So now if you look at MSI, this is something which would be endometrial, high grade, lymphovascular space invasion. And then, they are high BMI, there could be Lynch syndrome associated. So look for that. And then if you look back for P53 mutated, they are the one who have high copy. They are the worst. Beauty is it can be identified by IHC. When you do it, at least ask your pathologist, please do ERPR, HER2/neu, MSI, and P53 by IHC. Then decide only those patients who need Pole. Because stage 1, if they're all favorable, you don't have to do anything. Stage 1B or 2, then you can go back to Pole and see, can you avoid all this treatment? And they are the advanced disease, they onset late. Now I look back each one of them. So Pole mutation is in 10% endometrioid, relatively young woman, high tumor grade, high mutation, classified as high risk, exceptionally good prognosis. Treatment de-escalation, no RT for low stage. You can omit chemo even for higher stage, intermediate and high intermediate. So look at the recurrence-free survival with RT, with chemo RT, or with just surgery. Practically, they are same line. So this is a good thing to have if you can have, but expensive test to do. Then if you have MMRD, remember MSI, MMR are counterpart. One is by IHC, the same thing can also be checked on an NGS. So whichever you have, you can do. It's based on a molecule you have. They are sporadic. They constitute 20, about 1/3 of endometrial cancer, and they're high grade. Large number of tumor infiltrative, lymphocytes are there. They respond well to RT. So don't miss radiation if it is indicated, like 1B, or it is stage 2. So it's very important. This helps us to know radiation. P53 mutation helps us to know who needs chemo, and then Pole mutated helps us to know where both can be avoided. So I'm trying to simplify it because I read about 100 paper to come at this point. So I'll put it simply, if I can't give a good message. Then, P53, now here you see the Kaplan-Meier curve. There is somebody in US FDA, we always laugh. If you have a new drug, medical oncology is what they love. The costliest drug with small benefit, they love that. What is the benefit? 2.5 months overall survival for 50 lakh rupees. Immediately path changing, path breaking. And it's always told that you take on laser point. If we can negotiate this laser dot between the two curves, utna jagah hai, US FDA will come. Approval. So here you can see how much difference is there in between these two. They significantly benefit with chemo. So don't miss this. These are the patient, even if they are node negative, they benefit. This is the best thing you can do. And remember, the chemo for endometrium is not a very high toxic chemo like fulfiri or irinotecan, oxaliplatin. It's just a paclitaxel, which is very, very, very easily tolerated. Many times 4 cycles. GOG trial showed that 4 cycle of paclitaxel in endometrial CA is equivalent to radiation to para-aortic, because we don't want to give radiation to para-aortic. Kidney is knocked out, duodenum knocked out, bowel adhesion, intestinal obstruction. And if you extrapolate that on this data, P53, it is equivalent to para-aortic treatment, no RT to para-aortic, chemo gave a survival benefit. Look at the survival benefit that we had. Roughly 60% are alive, otherwise 20-30% only are alive. So P53 for chemo. Doesn't matter, early, advanced, please add chemo. Okay. Now, this is the part which we need to, but the beauty of this is, these are all done on IHC, which is very easy. So based on this marker, MMRD, P53, Pole, we classify now endometrial cancer into 4 varieties. If you extrapolate the PORTEC trial, What is POTEC initially showed? It showed that if you are adequately staged, node negative, EBRT plus Walt brachy is equivalent to Walt alone. So don't give unnecessary EBRT, over treatment of low risk. We are replaced now with no EBRT in endometrial, adequately staged node negative to brachy. Then it also went one step ahead and looked at it. So EBRT doesn't have overall survival benefit. Surgery and chemo has or not. Then we want to see, can chemo replace radiation? So if you study the POTEC 1, 2, 3, beautiful. Now extrapolate POTEC 3, they say ideally you do POLE. If it is mutated, very good. Kuch khas kuch karne ka hai nahi hai. But this in India take 40 to 60,000 rupees. Everywhere it is not available. Only 2 labs in India today to do it. So this is the right way. Then if it is wild type, then we know it is bad. Then you do MMR. Then you looked at it whether it is proficient or stable. If it is stable, you are still in good. If it is unstable, then add P53, wild type good, mutated bad, then go to chemo RT. This is nice in US, not. So we start ulta like this and we come last because I do P53, I do MSI, MMR, ERPR, HER2/neu. If all are stable and it is intermediate stage 2, now I don't know chemo RT to give, then last I do this. 2 labs in India do that. I sent to them, one in Bangalore, one in Surat. And they charge between 40 to 60,000 rupees. So that way, 5% of the only intermediate risk patient would need this. But ideally, if you have all, you do this, then this all can just go off. So this is what is molecular testing, which is very, very important for us to understand. So based on this, we have 4 varieties. I will not bore you. The same way how you work out, you need to look at it. Remember, most of it can be applied to clear cell and serous endometrial, even though endometrioid variety is what we do. So to start with, it is POLE, then last is P53, but these 2 are easily available. You can look in the other organ. So based on this, we classify into 4. POLE unmutated, MSI hypermutated, copy number low MSS, and copy number high serous-like picture where all of them are treated like stage 3 CCA ovary. Then down the line, you look at the somatic copy, histopathology, the grade, then PIK3, then KRAS, T53, and this prognosis. See, POLE, excellent, MSI, intermediate. Then if it is unstable, intermediate. And if you have P53 or high serous, like poor. So essentially playing around all this. I hope I'm not confused. I made it very, very simple. Then we arrive at this beautiful survival benefit. Look at it. POLE, followed by MMR. Then, we have the stable. The worst is P53. And we have small group unclassified because they could either be a metaplastic carcinoma or a carcinosarcomas when the things change on the either side. So this is now, whenever you do a new classification, you have to validate it to apply. So they use the POTEC 3 data. There was a 410 case, 93, 51, 131 of all, and that could extrapolate exactly what we told. Like if you do P53 mutated, 5-year only 48% alive, PFS. So which is true. Then you see that if POLE is mutated, 98% is alive, which I told no further treatment is required in intermediate, high intermediate, then MMR, and then, NSMP. So this has been, accredited and validated in this. And so we have now the new classification here. How the old ESMO, SGO, ESTRO has been incorporated. Don't get bored. It is too busy, but I have summarized. I have a last slide where I'll give 1, 2, 3, 4, 5 spoon feeding message. So don't worry about it. I'll give the slide if you want to read. So see that now. All POLE are low. You have a high intermediate where you have MMR deficient and they're stage 2. Then you have high risk when P53 is incorporated with this, and then the worst one where you have PFIT. So essentially, this is matching this particular area for you to do. So what is the impact of new guideline? All POLE mutation, even though they are stage 2, low risk, no chemo, no radiation. All P53 abnormal, high risk, irrespective of node positive, negative or not. Then if these 2 are not there, then you have MMR RD and then the stage which is incorporated for you to do this. So this is essentially the treatment algorithm which I told. So if it is P53 needs chemo radiation both, then if it is P53 not mutated and then POLE not mutated, then only you use DMMR, then no chemo only radiation. Remember, this is an indicator of radiation. P53 indication for chemo. Pole to avoid everything. So then here you can take RT and hormone therapy. So this is a beautiful treatment, which is called as a rainbow umbrella of what I spoke, everything. And this has been now incorporated in ESGO risk published in 2020, what I exactly told. So the old low, intermediate, high has been totally incorporated. If P53 is there, all fall into high risk. And then if pole is there, all fall into low. Then if neither of them are there, then these two you can use MMR deficient. This has been acknowledged and published just now. Lancet 2022 called as a PROMISE 2 trial. Exactly what I told, the algorithm to be done. So how a DNA is extracted, next generation is done, and microsatellite stability. So you can go back and read this paper published, how this particular changed to do the testing. So when do you do pole? Actually, if you have stage 2 or intermediate and high intermediate, you're not sure whether can you avoid chemo RT, that is where you do pole. That is the group. If P53 is mutated, this has no role, they need chemo radiation. Okay, so this is the algorithm which has been given, published in April 2022, both BAGP and BGCS guideline, which I told. So in summary, pole is excellent. Intermediate group, you don't know chemo RT to give, please do this. PORTEC trial showed that adjuvant for intermediate high risk when pole is not mutated, P53 is not mutated, you can use MMRD. So this testing should be carried out in all non-low risk, which is stage 1 high risk and stage 2 to do that. And then finally, this is the final algorithm we arrive at to reach the best to worst survival to triage. And please read this recommendation, which is published. So Astro is adapted this very well, where to give radiation, where not to give. And then this is the latest publication which has come to follow this. So I will concise in the last slide. See, stage 3, stage 4, no issue, because they are all high risk. They're either node positive, peritoneal disease, and they need chemo radiation. Stage 1, initially we thought all stage 1 surgery don't need anything, or at the most vault brachy. Now no longer so. I will tell you. If there is no LVSI, pole is mutated, stage 1A, grade 1 to 3, no treatment. Only brachy if there are high risk factors, like more than 50%, but MMR should be negative, LVSI should be negative, and this is brachy. If the patient has 1A with myometrial invasion, grade 1 to 3, but P53 is abnormal, then they need EBRT and chemo, even though they are stage 1. So see how this thing got added up. So no under treating stage 1. Now, if you have stage 2, this is where you must do pole. If it is mutated, for all grades, for all histopathology, observation. How often? Stage 1B, then coming to 2. This is where it has changed. External beam radiation only, no chemo, if it is not pole, but it is, MMR deficient. Then extended radiation and chemo if they are P53 in stage 2. So how much de-escalation in stage 2 happened? Escalation in stage 1 happened based on this. Stage 3B all need this. So the decision now is no longer simple, no positive, no negative, robotic done, laparoscopy done, parietic looked, not looked, less than 2. Almost one day will come, people will forget those morphological values. So decision is totally based on risk stratification and molecular marking. So you must have what is there available by IHC, please do it to save the cost. Then come back to pole in intermediate stage and appropriate chemo and radiation to them. Thank you very much. I think all clear now. Thanks.